We should be getting started momentarily. I'm just bringing the people back in from the breakout rooms. Thanks everybody for joining.
Good afternoon and welcome. My name is Vanessa Spearman McCarthy. I am the chair of the National Alumni Association of Spelman College Health and Wellness Committee. And we are so pleased to present today's program, Endometriosis Awareness, What Your Mom Did Not Tell You. For those of you who are unfamiliar with endometriosis, endometriosis is an often painful disorder in which tissue similar to the tissue that normally lines the inside of your uterus, or the endometrium, grows outside of the uterus. Endometriosis most commonly involves your ovaries, fallopian tubes, and the tissue lining your pelvis. Endometrial-like tissue may be found beyond the area which pelvic organs are located. Other areas of tissue implantation include the outer surfaces of the uterus, bladder, ureters, intestines, rectum, and the cul-de-sac, which is the space behind the uterus. Endometriosis has been thought of as a Caucasian woman's disease. However, we have been left out of the conversation. Endometriosis is a disease that very much affects African American women. And unfortunately, many of us are diagnosed later in the course of our illness, which results in unnecessary pain, unnecessary surgeries, and unnecessary infertility. So we hope that by the end of our presentation, you will be informed, inspired, and empowered. We have a wonderful program for you guys today. We have a panel of endometriosis warriors, we have a panel of clinicians, and then we'll open it up for a question and answer session. So without further ado, I'd like to introduce our endometriosis warriors. Ms. Kimberly Terry. Kimberly Terry, a native of Augusta, Georgia, is committed to humanitarianism and community service to the greater Augusta area. She is a 1988 graduate of Spelman College, a 2002 graduate of Troy State University, a 2013 valedictorian graduate of Training for Life Academy as a certified nurse assistant, and she's also completed 2 years doctoral studies in clinical psychology. She spent many years serving the government as a United States federal investigator. Though she's medically retired, she has not let grass grow under her feet by any means. Kim is the president of Women of Purpose and Power Incorporated, a nonprofit organization founded by Georgia State Representative Gloria Frazier for the purpose of providing social, educational, economic, mental health development, and assistance to those families and people in need of services in the greater Augusta area. She also holds offices in numerous civic boards and philanthropic organizations. Additionally, she volunteers with several health-related organizations, including Sickle Cell Foundation of Georgia, Lupus Foundation, Neuroendocrine Tumor Foundation, and the Kidney Foundation. She also volunteers routinely through her sorority, Alpha Kappa Alpha Sorority Incorporated, Alpha Alpha Epsilon Omega chapter in Evans, Georgia, and the National Alumni Association Spelman College Augusta chapter. Kim is an endometriosis warrior for over 30 years. Her dream is to show others that no matter what cards you are dealt in life, you can still serve your purpose in life by giving of yourself and helping others, because that's your gift from God. Mrs. Katrina Moore Belser. Katrina Moore Belser, a Chicago native, is a graduate of Spelman College with a Bachelor of Arts in English. She holds a Master's of Divinity degree in Scripture and Interpretation from Emory University Candler School of Theology and a Master's of Arts degree in Children and Family Ministries from Bethel Seminary. Growing up in Illinois, she knew that she was called at an early age to work with and be an advocate for children, and has taught both in the Atlanta, Georgia, and Augusta, Georgia areas. Currently, she serves as the elementary school principal at Curtis Baptist School in Augusta, Georgia. In addition to her duties as being principal, Katrina is very active in her community. She and her husband are members of Greater Young Zion Baptist Church of Augusta, where she actively serves in the Christian Education Children's Department. She serves on the board of directors for the Augusta Symphony. She's active in her sorority and serves as the president of the Zeta Phi Beta Sorority Incorporated Tau Omicron chapter. And she also serves as the vice president of the National Alumni Association of Spelman College Augusta chapter. Katrina has been living with stage 4 endometriosis for over 4 years. She is a warrior of the disease and seeks to educate other young women who are struggling with this tumultuous and mysterious disease. So, without further ado, I present to you Ms. Kimberly Terry.
Hello, everybody. Thank you so much for allowing me to share my story with you. Originally, when I was asked to do this, I said, let me prepare this long speech for you guys. But then, as I thought about it, I said, the best thing for me to do is to simply talk to you about the life that I have living with endometriosis, or as I call endometriosis, my faded rainbow. And I know you don't understand what that means right now, but by the time I get to the end, you will understand. Just keep in mind my faded rainbow and you'll understand. I began my cycle at the age of 11. And I don't know about you guys, but I am 55 years old. So my mom really didn't explain to me what a period was. So all that time, I thought that the punctuation mark, the period, was just going to fall out. So I was sitting there waiting for a period. That didn't happen. So when I got my period, it was like extremely heavy. So I'm thinking, why is this so heavy? Well, anyway, I had cramps, like very bad, heavy, heavy, heavy cramps, just to the point where I almost passed out. Well, we went on with this over and over. My mom just said, I had cramps when I was when I was young, I'm sorry. So it's just the way it is. This is a woman's thing. Makes you becoming a woman now. She said, my mom had that. This is the way it is. So I went on for years and years and years with that same thing until I began junior high school. Every day, the first day would be the worst. My cycle would last from 7 to 10 days. It got longer and longer and then heavier and heavier, and I would clot. But I thought this was normal because I wasn't educated, and probably my mother wasn't educated. It was a generational thing. They told you just had to go lay down and take a few meds. So, it was just one of those things. Well, then it was after high school. They didn't really get you on medications. They just said, well, you can tell your doctor about it, but it was no big deal. And the doctors I had at that point gone to a gynecologist, um, and he just sort of brushed it off. He didn't really make a big deal out of it. He just said, well, as long as you're okay, he didn't bother to make any kind of checking me out or doing anything. But by the time I got to, I believe it was maybe 12th grade, um, he said, well, what we can do is maybe put you on some light, low estrogen birth control pills. And I said, okay. But the first dose that he gave me made me extremely nauseated. So I was like, I don't want to do that. So then they tried me on another set. I went through probably maybe 4, 5 different types until I found something that I was actually able to tolerate. At this point, it is time now to go to Spelman College. So I get to Spelman, and then the pills actually began to shorten the cycle. So my cycles are at this point 3 to 5 days. They're much lighter. The pain is better. And I'm thinking that everything is well. And I'm thinking, okay, well, there's nothing wrong. They didn't do any other testing on me. The summer of the freshman year, I was at home and I started having extremely bad cramping in the lower part of my abdomen. And when I would try to have like maybe bowel movements and stuff, I would have stabbing pains. It felt like somebody was taking a knife and just stabbing. And it would happen mostly during the time that my cycle would come on. And I remember going into probably, I think it was like a just particular day. I just seemed like I had like a stabbing pain. I almost passed out. I had to be rushed to the emergency room, and they told me that I had a bowel obstruction. And when they got in to do the surgery, I wound up having uh, the top half of my small intestine removed. They said everything was fused together, and I had endometriosis. At this point, I had no idea about what that meant. They said that also it had wrapped around my appendix. And so at that point, to me, now looking back in hindsight, that would have been the perfect time to educate me about this disease. Okay, so the only thing that happened was I recovered from surgery. I came back home. It was time to recover, and I came back to Spelman College that following year. This was the summer. I went right back to Spelman, went back to school. I called that one at now my stolen moment, because that was my moment to get educated. That was my teachable moment that somebody should have said, either the surgeon or my gynecologist, give me information. I do remember somebody giving me a pamphlet. I do believe that. They gave me a pamphlet and says, here, read this. But I didn't know. Um, the next 2 years went well. And I think at that point, after the graduation at Spelman, I came back, and then in 1993, because I graduated in 88, in 1993, I went to see an infertility specialist, a reproductive endocrinologist. He also specialized in vitro fertilization. And because I was beginning to have pains again, because after that, I didn't have any, that time frame after that, I didn't have any major problems. But the time after that, I was beginning to slowly start to experience the same type of feelings. And that's what led me. He says, well, listen, I think you're probably getting scar tissue again. So let's go ahead and do a surgery to remove the extra scar tissue. Um, I said, okay, that's fine, because I didn't know any better. I went into the surgery. I wake up with no ovaries, no fallopian tubes, and I'm just like, I have no clue what is going on. He said, oh, you just had so much endometriosis. And he said you had a huge endometrioma at the base of your rectum, and we just had to get it all out. And I said, well, was there some kind of cancer or something, or was my ovary getting ready to rupture? Why did you do that without saying anything? Oh, well, we just didn't know. We just didn't want anything to mess up on you. That's the only, thing he could say. So that was the end of that. And then from here we are. I was just like, well, at this point, I didn't know. I didn't know. He says, well, you're in surgical menopause. I just want you to know that. So you're probably going to have to get on some hormone replacement therapy. Needless to say, I had no clue what hormone replacement therapy was going to actually do to my physical body. I didn't know that losing my ovaries at that time was going to have such an impact on all of my body systems, not just my female parts, and how I was really going to feel. So we went from there to me experiencing really what that meant. And I began to have the serious hot flashes, not just the gradual change of your ovaries and the flashes and things, but it went from depression to your hair change, your thinning of hair, your skin change, to the vaginal dryness. I mean, serious cracking of your vagina tissue. Um, I had the memory loss, which was terribly bad. I developed cardiac disease. I had a heart attack. The following year, I developed lupus. I developed degenerative bone disease that I'm being treated for right now. They said, the lack of estrogen just took a very much of a rage on my body. And then they finally decided to put me on hormone replacement therapy, estrogen injections, which the rest of my life, I've taken them still now. Every month I have to take hormone shots. And it's just been totally devastating to have to go through all of these things, because your vitamin D you've got to take, because I have vitamin D, loss. It's just a lot. So the bottom line is, had I been educated, I would have made a different decision before allowing the gentleman, doctor, I should say, to even do the surgery. I was too quick to say, yes, go ahead and do this surgery. So I say all that to say this: even though my rainbow is faded, I challenge you all to use what these ladies are about to educate you on to keep your rainbow bright by becoming educated and listening to what they have to say. That's it. Thank you.
Thank you so much for sharing that. It's an amazing testimony. And next we'll have Katrina Moore-Belser.
Hello, everybody. Again, I am Katrina Moore-Belser, and I just want to say kudos to you, my Spelman sister, for sharing your story, Kimberly Terry. And I'm just excited to be here today to talk to everybody a little bit about my journey. And as Dr. McCarthy just said, I'm a native of Chicago, Illinois, and born and raised, and I will always rep my city. I've been in Georgia for a long time. This journey started around the same time my sister, Kimberly Terry, has said. I started my cycle when I was 11 years old. I was pretty early with that. Same thing, you heard about Aunt Flo, and I said Flo is a mess, and Flo need getting on my nerve, and you learn how to sit in a warm bath. She learned how to take the medicine. My mom, I had the advantage. She is a nurse, and she taught me everything I needed to know. It was just the way it is. You had pain, you dealt with that. You modified your diet so that it wouldn't be so bad, but it still ended up being painful regardless of what you did. And so then fast forward to college years, excited, get to Georgia, get to the ATL, and I'm at Spelman and just learning all of this stuff, but I am constantly in pain. I'm doing my whole schedule around the painful lifestyle. Now, again, I had no idea what endo was until recently. So we pause for a second. We're in college. We get to freshman year. We get to sophomore year. I have my classmates who are on the line. They remember, she would have certain times where she would be in excruciating pain. I still pushed through, but that was just what I dealt with. We never knew what it was. We just didn't know. I would do my schedule around my cycles. And then I found that I would do my schedule around my cycles so I wouldn't have certain things to do when I'm on my period, but then I had pain all month. So it was just pain. And you just thought that's just what you dealt with. So get into later on into the 20s. And the 20s were the 20s. I don't want to go back to the 20s, but it also added up to, getting the education, staying focused, making sure that that I am, and they knocked me out because somebody called me. Oh, goodness.
You're still here.
You're still here.
Okay. All right. Sorry about that. So I get into my 20s and everything gets crazy, and I'm focusing on my education, but I'm just still in so much pain. I'm still just really in a place where I don't understand what's going on with myself. I don't understand why I'm always in pain, but you learn to deal with it. You adjust your diet. You focus in on what you can and cannot eat. I started, I think it was towards the end of college, where I I went on a fast, and I eliminated meat from my diet. And so I noticed a big difference in my body. I didn't have as much pain, but it was kind of there. Then later on in my 20s, I meet my now husband. We get married. We're planning our life. And a couple of years in, I'm teaching at school, and I pass out in front of my first grade class. I'm rushed to the hospital. The first thing I have to do is I have to go into surgery immediately. And the man comes and says, it's endometriosis, the same talk. You have all of these tumors or these cysts, and they have to take all of this stuff out. I was fortunate that they didn't have to take out everything, but they did have to do a lot of surgeries. But just in a 2-month span, I had to go back into surgery, another emergency surgery. In the midst of that, I'm not understanding really what's going on. I'm trying to update my family. I really don't know what to say because I personally don't know what's going on. I'm just in pain. I'm in surgery. I know I'm a teacher. I'm a new wife. I'm just trying to be, and I can't. So all of that is going on. And so the second time around, they sent me to a specialist here. He's a fertility specialist, and he did the second surgery. And he said, not only was it endometriosis, but you have stage 4 endometriosis. And basically, after the first surgery, that's when I started doing all this research and learning a lot about what it was, got connected with Endometriosis Association of America. If anybody knows me, I bought a bunch of books, and I'm studying, and I'm talking to my mom. I'm going back to her old nursing books, and I'm talking to people trying to understand, because people are asking me, of course, you're at this stage in your life where you're married, and they ask you, okay, hey, you're going to have kids? Is this what you're going to do? And although I understand now it can be an invasive question, you want to have an answer, and I didn't have an answer. And so got connected with that, and then really adjust my diet. And I'm going to constantly say that because it was a lot of inflammation and things that triggered. Now, I wasn't a horrible eater. But back in college, I don't know if it's still there. They had, what do they call, Wing Zone, Wing Stop or whatever. And I would eat real good. And then I would just have me a bunch of wings. I love stuff like that. Or I'm a big sweets person. I like pastries and things like that. So I had to cut out a lot of like sweets, and I had to cut out a lot of like dairy in my diet, and just learning those different intricacies, learning about the herbal teas. I can't do a lot of caffeine and things like that. I learned that through this crazy journey. Less stress. I was, anybody that knows me, I'm a bit of a workaholic. I will work. I will work because I love what I do. And sometimes I did it so much that I just didn't take care of myself. And you really don't get slapped in the face until you are pushed down or you can't perform or do what you need to do. And I had to learn the hard way. I also had to learn the hard way when you're sitting having those conversations with the doctor right after the surgeries, and they're asking you, okay, what are your next steps? What are your plans? What happens if you don't make it? Or what happens, what decisions would you like for us to make? They're talking to my husband about different things that we didn't expect to have that conversation starting off. And so just dealing with all of that. When I think of endometriosis, I think of, I told Dr. Vanessa to make sure she called us warriors, because I didn't want it to be a thing where I was constantly singing a sad song, because we are pressing through trying to learn about this mysterious disease. But I also learned how I needed to take responsibility for my health. Gone are the times where you go in and they tell you what's wrong. You walk in there and you have your notes and you have what you've been experiencing, and do your best to articulate that to your doctors so that they can understand and help you. It's a collaborative thing with your health. I think this is something that I really wanted more of the younger Spelman sisters or younger women to learn more about, because I didn't know. I didn't find out. I'm 35 now. I didn't find this out until I was like 32. And if I would have known now, if I would have known then what I know now, I think it would have went different. But we go through things for a reason. And so I see myself as a warrior. I see myself as an educator, and I'm still learning. And I want everybody on this call to be able to transfer that information to others that are experiencing that weirdness and they don't know how to put words to it. We're trying to help you put words to that. I'll leave you with this. This is a constant journey. I identify with two people. I'm a Christian, and I know everybody may not be a Christian on this call, but it's two people in the Bible that I identify with that I didn't realize it until I started having this journey. The woman with the issue of blood, I see myself as pressing towards Jesus. And the way I'm pressing is I'm educating myself. I'm trying to understand what's going on in my body. I'm not trying to tell Jesus what to do because he already knows what to do. But I'm pressing towards trying to understand how to be healthier, because what I want to do is give God glory, and I can't be sick doing that. And so that's my prayer. I also have a specific prayer, Hannah's prayer. Hannah went to the Lord, and she had some concerns, and her specific concerns was that she wanted to have a child. Well, that's my prayer as well. I identify with Hannah because I don't know. We don't know if Hannah had endometriosis. We don't know, but I can identify with her having desires and going to the Lord, not really knowing what to say, and people looking at her saying, well, what is she saying when she's praying? But God knows. And so I use that to motivate me to show other young women who may experience this type of pain, but they really hadn't been able to put words to it. But now you can. It is not normal for you to be in pain and vomiting and all these surgeries and trying to understand that, it's not normal. And it may be something. I'm not a person that I can diagnose you, but ask the questions, be aggressive about your health. And if you don't know, just say it. Just put it out there, talk about it, so that you can find out more information to find out what's going on, because you may not only be saving your life, but you may be saving someone else's life. Thank you.
Thank you so much, Katrina, for such a powerful story. And again, thank you, Kimberly, for being authentic and vulnerable to help us learn. And now the next portion, you talked about, getting the clinical information and the expertise from our clinicians. So this is our education portion of our program. And we have three wonderful Spelman sisters who are clinicians, and I will introduce them. The first is Dr. Karen Johnson. Dr. Karen Johnson is an obstetrician and gynecologist with University Health Women's Care in Lee Summit, Missouri. She was born and raised in Buffalo, New York. She attended Spelman College in Atlanta, Georgia for undergraduate studies, where she majored in sociology. And after college, Dr. Johnson received the Master's of Public Health degree in epidemiology from the University of Illinois at Chicago School of Public Health. She then returned to her hometown for medical school at the University of Buffalo School of Medicine and Biomedical Sciences. In 2004, she continued her medical training in obstetrics and gynecology at Duke University Medical Center's residency program in Durham, North Carolina. Prior to joining University Health Women's Care, Dr. Johnson was in private practice with DeKalb Women's Specialist in Decatur, Georgia from 2011 until June 2019. She has special interests in women's health disparities, management of uterine fibroids, endometriosis, and quality and safety in healthcare. Dr. Johnson enjoys gourmet cooking and dining, vegetable gardening, traveling, and spending time with her family and friends. Dr. Yvette Poindexter. Dr. Poindexter is a board-certified obstetrician and gynecologist and a Spelman College graduate. She completed her Doctor of Medicine at the University of Texas Medical Branch in 1993 and her OBGYN residency at Baylor College of Medicine in 1997. Dr. Poindexter has practiced in managed care, private practice, and community health. While pursuing her Master's of Business Administration at West Texas A&M University in Healthcare, Dr. Poindexter has guided the clinical and financial growth of a community health center with expansion and increase to 12 sites. Dr. Poindexter implemented medical, dental, and behavioral health services in Brazoria, Galveston, and Harris County while expanding clinical services to specialty care and clinical research. Dr. Poindexter has mentored and precepted professional students, resulting in outstanding accolades from major universities, including HBCUs such as Prairie View A&M University Nursing School and the University of Houston College of Medicine. Other experience involves NCQA, patient-centered medical home recognition, chronic care management, care coordination, population health, telemedicine and telehealth, primary care oral behavioral health integration, remote patient monitoring, medical withdrawal and detoxification, medication addiction treatment, and 12 years of clinical research experience in general medicine and women's health principal and sub-investigation. The recent acquisition of advances in health by Community Health Network will afford Dr. Poindexter as the Director of Clinical Research to support the education of African Americans and minorities for equity, diversity, and inclusion in clinical trials. Dr. Ariel Dance. Dr. Dance is a 2010 Spelman College alumna who resides in New Jersey with her wife, Stevana, and Chihuahua Terrier Minnie. A published children's book author, Dr. Dance's debut book, Dearest One, is a heartfelt love letter that taps into grief, loss, and life lessons from our ancestors. When she's not writing for little ones, Dr. Dance is writing about health-related topics in our community and advocating for health equity. Most recently, you can find Ariel's piece, Working Through the Death of a Colleague, in the Harvard Business Review. Within her community, Ariel is actively involved in numerous initiatives. She is active with the North Jersey alumni chapter of Delta Sigma Theta Sorority Incorporated, including co-chairing the Physical and Mental Health Committee. Near to her heart, Ariel serves as the ambassador for World Thrombus Day, fearlessly sharing her blood clot survivorship journey. She is a member of the Northern New Jersey chapter of the National Alumni of the Spelman College, where she has served previously as vice president. Ariel is a researcher of reproductive health topics and an endometriosis advocate. Her doctoral research focused on non-invasive coping mechanisms for endometriosis and specific relaxation techniques, including meditation, deep breathing, and guided imagery. Ariel empowers those with chronic pain to break the silence and stigma related to their illnesses and advocate for their rights. In her writing and in her community service, Ariel is focused on highlighting invisible illnesses, coping with life events, and dancing through every circumstance. We will now hear from Dr. Kieran Johnson.
Good afternoon, and thank you so much for allowing me to participate in this webinar. Thank you to the patient warriors who have already told their stories. I sit as a participant and as a presenter on this webinar. But I want to start out with a quote. And this quote just signifies and kind of comes to mind every time I think about and treat endometriosis. And that quote is, "If you are silent about your pain, they'll kill you and say you enjoyed it." And that's by Zora Neale Hurston. I believe it's from Their Eyes Are Watching God. And we've already talked about how pain is one of the main symptoms of endometriosis. And that quote just makes me think and makes me be cognizant of that when I'm dealing with patients and seeing patients with pelvic pain. my role as an OBGYN, I see patients for their well women exams. I see them for their problem visits. And I just want to go through kind of how a patient presents and how the interaction with an OBGYN or a OBGYN provider and how that kind of rolls out. So I will see a patient will present for her well woman visit, and we do the preventative health visit, and patient will just, will present for her well woman visit. She's coming in for her pap smear, her annual pap smear, pelvic exam, breast exam, right? And I may talk to them about how they've been doing for the last year. And they may say, everything is the same. But when you delve in a little bit more and you ask about, well, how are your periods? As one of the main questions in the GYN history, they may say, my periods are like they always are, but then when you delve more, that may mean that they're in bed for the first day of their period. And they go along thinking that is normal because it's been that way for most of their life. And these patients I'm seeing predominantly are in their 20s and 30s. And when you delve in more, you start to think about, well, that's not normal. Let's talk about that a little bit more. And I want to kind of caution that first visit may be a well woman visit. That scenario plays out often. And that well woman visit isn't usually sufficient to really delve into that painful period complaint, or the pain with intercourse complaint, or with talking further, they may say that they have pain with every bowel movement, or more pain with their bowel movements when they're on their period, which is something that Kimberly talked about in her warrior statement. But so that visit may lead to multiple visits or a follow-up visit. So, and that's important to know because oftentimes when we're making a diagnosis of endometriosis, it does entail a process. And sometimes it may be on average 6 to 11 years with from the time of symptoms to diagnosis. So just going back to that visit, in follow-up, it may be, well, let's go further. Let's talk about this more. Let's first do an exam and see how your exam, you may have tenderness on your exam. With a pelvic exam, there may be tenderness around your cervix, tenderness on your GYN exam where by manually touching your uterus, you may have pain there. And you may feel on exam, you may feel some nodularity. And usually those kind of symptoms will then prompt further evaluation. And generally speaking, one of those follow-ups may be a ultrasound. And an ultrasound is not necessarily going to diagnose the endometriosis. The diagnosis may come with further evaluation. So we have the ultrasound, and the ultrasound may show nothing at all, right? But that does not end the evaluation, right? So great. We've done the ultrasound, we've ruled out that you have a large cyst, or we've done the ultrasound and we do see a cyst. And that cyst may be endometrioma. And what Kimberly discussed in her, Katrina discussed in her warrior statement. We may be able to see that on ultrasound. Now, the presence of the endometrioma may be diagnostic, but the absence of it does not rule out the diagnosis. We could see changes around the bladder on ultrasound. We may see changes behind the uterus on ultrasound. So that's one of the first steps. So the presentation, we get a good history. And one of the roles of your patient experience is that when you come to that visit, either that annual exam visit or the follow-up visit, having a detailed log of your symptoms is really important, because pain can be so subjective that it's hard to try and translate what your symptoms are to your provider. So if you keep a calendar of when it is that you have pain, is it, and in relationship to your menstrual cycle, so is it leading up into your period, is it during your period where the pain is more intense, and does it resolve after your period ends? So keeping a log of that for several months is very powerful in kind of illustrating what your pain is to your provider. So we've done the ultrasound, and let's say we have a follow-up visit. Sometimes we can make the diagnosis of endometriosis just based on that, right? And there's kind of two kind of processes in making the diagnosis. Sometimes it can be clinically made based on symptoms, based on exam findings, based on ultrasound findings. And then we can go down the road of treatment at that point. That's acceptable way to approach it. So we can go down the lines of using oral contraceptive pill or progesterone only form of either birth control or therapy. We could try a IUD, medicated IUD, like Mirena or Skyla. Those are levonorgestrel or progestin only IUDs. So that's totally acceptable to do. And we can approach it that way in a least kind of or less invasive approach to diagnosis and treatment of endometriosis. Now we can do that and see how things go, see how you respond to that treatment. And we do that with then follow up and check in to see if you're getting response. And it's very important that I make that point of follow up and check in, because I don't want my patient to then feel like, oh, I've given you this pill, I've given you this treatment, and see you later. No, you have follow up to see, okay, is it effective? Now, the effectiveness doesn't necessarily confirm or rule out endometriosis. But if we find that our prevailing diagnosis is endometriosis and we don't have improvement in with the least invasive or less invasive treatment, or that first line of treatment, then our next line of evaluation may be with surgery. Now, we'll say in the textbooks that gold standard of diagnosis of endometriosis is done surgically. And what we do is oftentimes do a laparoscopy, which our patient warriors have discussed. A laparoscopy where we put a camera inside your abdomen, which is an outpatient surgery. You're asleep for it. And we're able to look around your ovaries, fallopian tubes, your uterus, both in front and behind, and look for signs of endometriosis. And those signs can sometimes be subtle. And sometimes what we see doesn't necessarily correlate to the pain, right? So some patients can have excruciating pain, and on laparoscopy, we see minimal signs of disease. But that doesn't discount the fact that your patient has severe symptoms. So endometriosis can be oftentimes tricky. Sometimes what we'll see is endometrial implants. We may see scar tissue. We may see organs that are attached to each other, which is something that Kimberly had described in her diagnosis. And so that laparoscopy does two things. It can be used in aid of diagnosis and can also be used in treatment. So we can resect scar tissue, we can biopsy tissue, and that way we're able to get a histologic or tissue diagnosis of endometriosis. And if we're able to remove as much endometriosis as possible, and then that can translate into improvement in pain. I also want to make sure that I express that there is not a one size fit all approach to treatment. And that's true for a lot of GYN diagnoses and problems. It's not one size fit all. We have to think about what is our goal for treatment? What is our goal for management? And some patients may have presented because they're in excruciating pain, right? That's one of the main ways of diagnosis or ways of presentation. We may have patients who have been trying for pregnancy for over a year and have been unsuccessful, and this is part of their evaluation for why they are dealing with infertility. And so the goal for that patient may be to get pregnant. So, and I say all that to say, it's sad for me to hear that Kimberly's experience of waking up and then finding out that she's in surgical menopause, because that conversation should have been, what are our goals for treatment? And if our goals for treatment were to preserve fertility, waking up to find out that you don't have ovaries, you don't have fallopian tubes, even if that is ultimately what the treatment is going to be to control pain, that was not our goal, because it may have been the goal to get pregnant. So we have to just take a holistic approach to our patient care. And that's probably one of the biggest takeaways about endometriosis and treatment for endometriosis, is that holistic approach. So going back to our patient presentation, we've done our laparoscopy, we've diagnosed the endometriosis, we've resected what we can of the endometriosis, we've preserved fertility, and we see our patient back for follow-up. And then again, we're talking about, okay, well, where do we go from here? And that's important because the patient may have had some improvement in her pain. We know that there is a chance after surgery that 8 out of 10 patients may have return or worsening of their symptoms within 2 years. So in that time frame, is it our goal to have a pregnancy? Is it our goal to be able to function with the least amount of pain or a less amount of pain than prior? And how can we extend that time from surgery and control of pain to a flare or extent of endometriosis? And so then we're talking about different treatment modalities in addition to having surgery. And that goes into our kind of our second line of treatment options. And those are in the family of GnRH agonist and GnRH antagonist. And probably one of the easiest ways to think about that is the GnRH agonist, commonly known as Lupron or Depo-Lupron, is an injection that can be given monthly or every 3 months. And it's usually time limiting. We will approach and use Depo-Lupron for sometimes a year. That's what it's FDA approved for. But in taking patients individually, sometimes we're in a situation where we extend that longer. The difficult part with Depo-Lupron is that some women will have symptoms of menopause after, because the way that it works is that it shuts down the ovaries. And it's reversible, but it does shut down the ovaries. And that's important because the ovaries are what are producing our estrogen, right? And if we go back to what causes endometriosis, it is estrogen mediated. And so if we can reduce the amounts of estrogen circulating, it will reduce the activity of the endometriosis. And then another second line of treatment is the GnRH antagonist, and one that is showing a lot of effect and treatment success is a medication called, the trade name is, or brand name is Orilissa. And that is a pill So it's a little bit better than having the injection, but it's a pill. It also can have some menopausal type symptoms or side effects, but both Depo-Lupron and Orlissa are those side effects are controlled well with hormone replacement or add back replacement of hormones. And so with that, we can get some improvement in symptoms. We can extend that time between having surgery and needing any further treatment in terms of surgery with the addition of the medication. So that's generally an approach that we can use for treatment, management, diagnosis of endometriosis. You know, I think those are probably some of the main takeaway points that I wanted to express today. And so I am open to any questions and we'll have time to do that. But those are the main things that I want us to kind of talk about in that patient interaction, patient-doctor interaction.
Thank you so much, Dr. Johnson, and we'll now have Dr. Poindexter.
Good afternoon, ladies. And if there are other persons on the call, of course, good evening, good afternoon to you as well. Well, this has been quite a good conversation as we started off with warriors, and then the education of Dr. Johnson just gave us. Now, just as I see that we wear different hats, I've seen a lot of different things throughout these conversations that we have had thus far. So some of the important points that I've taken away from this conversation, talk about education. Education to start early on. As an obstetrician gynecologist, I have always believed that education starts early on when we start seeing our gynecologists. But it can also start, and actually we start seeing the gynecologist later and later in life, right? But, I used to like to start that conversation early on with young adolescents because that's where you start seeing the dysmenorrhea or pain during your period, which is one of the most common symptoms. I also heard from a warrior collaborative management. I call it collaborative care. I've heard holistic care. I call it whole person care. There are different ways that we need to think about an approach. The other thing I heard from each warrior was shared decision making, that they did not have that shared decision making and woke up with something that they were not expecting. But what I heard during the educational piece from Dr. Johnson was the fact that we need to go into this conversation with determining the goals that we want to achieve. I usually like to look at things like outcomes. And some of my patients have questioned me in the past. Like, one of my main things to ask is, are you ready to have children right now? Do we want to preserve your reproductive potential? Because that changes my decision making a lot of times. Now, I agree in a shared decision making, but I'm going to try and help guide you to the best outcome that you are looking for. So today, I'm coming at you with another hat that I wear. I am not only an obstetrician gynecologist, but I'm a chief medical officer of a community health center that's located in Texas. There are multiple sites that we have, and was actually able to start women's health there in that community center. And why is it important in the community? Because it gives women the opportunity to receive care that they may not have received out there when they don't have those opportunities with private insurance, and maybe all they have is public insurance, or maybe they need some type of funding in order to just take care of themselves. So I have been lucky enough to been a principal investigator also for over almost 13 years now. And during that principal investigation for clinical research site, which we were Community Health Network just recently acquired, I'm now the director of clinical research and can bring clinical trials to a diverse population, because endometriosis has not received a lot of clinical trial attention. Even though I did participate, we talked about Orlissa. My clinical trial site did have clinical trials for Orlissa. So I can say I was a part of getting that FDA approved and on the market. However, I am here today to talk to you about us as women, as minorities, diversity in clinical trials, and getting us more involved. I am going to attempt to share my screen real quickly. And just tell me if you are able to view.
Yes, we are.
All
Yes.
right. So these are just a few slides, and I'm going to turn it on if I can see without my glasses. Slideshow, just real quickly. So historically, we know that endometriosis has not been considered a Black disease or a disease of minorities. The prevalence is low in African Americans and minorities. However, of the 10% of women that have endometriosis, we know that we are included, but maybe we're not included because we don't have a chance to get out there and we're not heard like a lot of women. So we're going to talk a little bit more in detail about that. And why am I talking about endometriosis? You saw my beautiful slide behind me because we talked about the way it affects us as women. There are different theories about endometriosis and why it affects us as women, but it affects different areas in our pelvic organs. One of the main things that we come to the doctor about usually is concerning pain. So one of the reasons why I wanted to bring this up is because not only being in the research field, there aren't that many investigators out there that are minority, that are African American. And I'm just going to talk about real quick. Y'all remember COVID vaccine and the hesitancy we had in the African American community about something that we could protect ourselves. We could protect ourselves from COVID. We, as African Americans and minorities, were the main people out there that were losing our lives. We talked about earlier, I heard the word disparities. That's what we are concerned about. So I'm here to discuss because I want to improve the enrollment of African Americans and minorities into clinical trials and just stop talking about all these myths. There are myths, but there also are hesitancies because in the past of what we have experienced as minorities. Now, just remember, there's very little research about endometriosis. So we know that we as African Americans and as minorities are often represented in clinical research. And there's a plethora of reasons for that. We just talked about education. We're talking about historic reasons like the Tuskegee Institute. There are just so many reasons. And I also mentioned about public-private insurance. So we suffer in a lot of diseases disproportionately. There's heart, hypertension, heart failure, other diseases, and a lot of times we just aren't included enough to even make a generalizable result to the population. And one of those is endometriosis. So just real quickly, what is a clinical trial? Now, all of us have probably taken a pill at some time in our lives, even Tylenol, prenatal vitamins, any of these things. These things have been studied before. They were in clinical trials before they could get out there and be safe and efficacious for us. There are different phases of a clinical trial. There are 4 different phases. The third phase is one of the most important because it shows and compares standard treatment with other treatments that are out there. And Orlissa was one of those. There are very few treatments out there for endometriosis that we just talked about, but this was one of the ones that was FDA approved. So what are we trying to achieve in a clinical trial? Well, we want to find new ways to help prevent, treat, and cure illnesses. Now, clinical trials can help us. They can help African Americans. They can help diverse populations all enjoy better health. Okay, and it will help so that we can find out. Remember, there was another comment made that treatment may not necessarily be the same treatment for all women. We might have to make that treatment according to what works for you, right? So if we don't have diverse populations in clinical trials out there, for endometriosis and other types of clinical trials, then we'll never know what works for us as African American women. So we mentioned earlier about pain treatments, and I think that they were explained so well, and the different steps that you go through just to get to treatment, and to get to treatment maybe even after you have surgery, and how it's diagnosed, how is endometriosis diagnosed. In gynecology, endometriosis has been a very challenging chronic disease for me as a gynecologist. Pelvic pain, period, is a challenging disease for me as a gynecologist. I have spent a year now going on, I guess, 23 years in gynecology, trying to understand why I didn't get that right sometimes about pelvic pain. I can remember a young woman that was 25 that I did a hysterectomy on, probably in my 2nd or 3rd year of after my training as a gynecologist. And she still creeps in my mind because she was Black. And I remember going through all the steps, did everything that we just talked about in the educational piece, but I still couldn't save her reproductive potential. But you know what? In the end, I always look back and say, but this was the goal and shared decision making and the outcome that we talked through and that she wanted. And it was not to save her fertility. It was to improve her pain. So each woman is different. So that's why it's always good for us to go as a woman and an advocate for your own health, to feel empowered, to develop a relationship with the right professional. I say the right professional because if you don't understand or feel comfortable or confident in the decision that was made, or you feel undereducated. I always tell my patients, it's okay if you need a second opinion. And most of the time, they end up coming back to me anyway, because I try and explain it to way a person understands. So going back to that collaborative care, clinical trials is a part of that, because we need to understand why our bodies may be different in disease processes, but we'll never know that unless we actually start enrolling. So I'm going to be an advocate for clinical trials also, because if I did a mini of COVID-19 vaccine hesitancy, which became confidence speaking panels every week for 2 years, with HUD nationally, with the churches in Texas, going to speak to pastors, all of these, because we and Hispanic chambers and minority chambers and African Americans and individuals, and I can go on and on. But the reason why we need this recruitment and participation, why is it suboptimal? Because of our relationships with our professionals, because of our trust, and we can start to change that. We can start to shape our own narrative. So the 3 reasons that I say are social economic disparities, lack of representation, and medical bias. So social economic disparities, why? Because social determinants of health, all these different things that we've talked about, income, wealth, education, employment opportunities, all of these things have an effect on the outcomes of health, and they're going to play a significant role in the use of trends in endometriosis related medical services, prescriptions, and people and patients that may have public versus private insurance. These are ways that some persons can even get other further assistance because they don't have insurance, because they're not educated. In clinical trials, we probably monitor you a little bit more than even your doctor might, because we're concerned about safety and efficacy of those things that we're in the trials for. But I am the doctor, that is monitoring. So I'm going to challenge those doctors who are here, whether it be for endometriosis or for any other disease process that affects minorities or African Americans, that we need to be more principal investigators out there. Because who do we trust? We trust our doctors. We need, we as women, African American women are only represented less than 3% of the population. So if we want to go out there and talk to our doctors about pelvic pain and why do I have pelvic pain or endometriosis, and the possibility of a clinical trial, we're the ones that can help change that and shape that narrative in our population. One of the other reasons that we need to get more involved is, because medically there is a lot of bias for us as women, for us as minority women, for us as African American women. A lot of times we are not taken seriously by medical professionals. They think we have a high level of pain tolerance. And then the diagnosis may become inaccurate because the doctor is not listening. So with that, if you know that you want to manage your health, or you want to another alternative, a collaborative decision about another way to look at your endometriosis or even pelvic pain, you can think about clinical trials. I'm in Texas, but these trials are all over. There are a lot of new trials coming out on endometriosis. A lot of times you do have to be diagnosed before, but sometimes you can go into these clinical trials just with symptoms, especially if you don't have access for insurance. They're highly monitored. Remember, clinical trials, they help to prevent diseases. They can help to learn how to detect diseases. They can look for new ways to treat a disease, just like Orlissa, that was found to treat moderate to severe endometriosis. It can decrease your cost when getting treated for endometriosis. Some of these trials will, they're in phase 3 where you can use certain medications that have already been somewhat out there for endometriosis, and they're just looking for a comparison to look at the standard, which there aren't that many for endometriosis. And there's the importance of diversity. You can also get compensated for your time spent. And just remember, participation equals representation in our community. So there are a lot of questions you can get out there and ask. But for the most part, and I can stop sharing if I can. Y'all might have to help me stop sharing. But for the most part, we know that there are ways out there to help with endometriosis. And thank you so much for everyone letting me be here today.
Thank you so much, Dr. Poindexter. It is so heartwarming to see you as a clinical investigator because we don't always see ourselves, and so that's amazing. Our last speaker will be Dr. Dance, Dr. Ariel Dance.
Hello, everyone. So I know that I am last, and I'm going to do my best to kind of tie everything in a little bow.
Excuse me, could Dr. Poindexter stop sharing her screen?
Yes, that's what I'm trying to do.
Go up to the very top, and it should say, and your drop down should allow you to stop sharing. Okay, you can go ahead. I just wanted to let her know we could still see.
Yeah, no problem. I'm going to keep talking, and you
Yes,
just do your thing. All right. So I'm going to do my best to kind of tie everything together or pull from where other people have spoken already without being repetitive. So I have the privilege of being both under the umbrella of a researcher as well as being someone who has endometriosis. So it's a unique position to be in, but I think this also will kind of tie in my topic, which is advocacy. There we go. Praise the Lord. Which is advocacy. And so I was diagnosed at 15. And thanks to my mom, I always say thanks to my mother and Our Bodies Ourselves book, a lot of advocacy went into my mom asking and advocating on my behalf. She requested that I have a laparoscopy. She was like, no, I'm pretty sure it's this thing in this book that my daughter has. And so what I'll talk about a little bit is about being your own advocate, but also outwardly advocating once you know what's going on. So outwardly advocating. So I consider this kind of like turning your pain or your story into something beautiful and something meaningful. And this doesn't just have to be endometriosis. This can be anything that's going on in your life, right? So for me, it was while I was at Spelman, I had endometriosis. I was sharing my story very openly, making sure that I told everyone what was going on. about endometriosis. And I feel really bad, Katrina, in hindsight, that our paths didn't cross, because maybe you would have been diagnosed a little sooner, because I had Spelman sisters who were diagnosed while I was there, because I was very open about sharing my story. And we celebrated Yellow Shirt Day, because yellow is endometriosis awareness color. I made sure all my friends were wearing their yellow. So if you see the three of us who have endometriosis are wearing our yellow today, we are very proud about that. We wear it with pride. And so I was getting everyone to wear yellow at Spelman while I was there, because I wanted everyone to know what was going on. I was advocating, I was sharing my story, and I was getting other people to share. And they were telling their friends, if you have a painful period, go talk to Ariel. If you have pain between your periods, go talk to Ariel. I knew about everybody's periods at Spelman. And I don't mind. I will be the person you call when you want to talk about your period, because at least I'm like helping someone, right? That means the word's getting out and people know that something's not right. And that's fine with me, because we need to share our stories. We need to break that silence that Dr. Johnson was talking about. So raise that awareness, join an organization, raise some funds, do something. But just because it's really painful, to your point, Kimberly, about that dim rainbow, it can be really painful, it can be really dark, but we have to find that brighter side of it, right? And we have to be out there and educating people, right? Then there's also that aspect of patient advocacy. Let's say you want to really help people, you really want to make this a job, right? You can be a patient advocate, you can really be there for people while they're having surgeries, while they're navigating what their treatment should be. I know there's students on this call, and you're like, I don't know what specialty to go into. I did not realize the options that there are in nursing, in medicine, in physical therapy, in medical equipment. There are so many options. If I had known at 18 that I could have been a pelvic floor physical therapist, mind blown. But pelvic floor physical therapy is so important for people with endometriosis. And I think, Dr. Johnson, you kind of stopped your treatment plan at Lupron. And I'm like, oh, physical therapy right there. Acupuncture, chiropractic, meditation. The treatment plan is so holistic, and we have so many opportunities as students, as careers, to go past that, to get our training and continue the advocacy past that. I would also put a plug here for health equity. If you're going to go into surgery, please know that there is a specialized surgery just for endometriosis. It's excision surgery, where you kind of get deeper into the tissue and remove it. But only a few people are specialized in this surgery. It's costly. It's out of pocket. It's out of network for a lot of people. And it's kind of like that because we can't afford it. And so I think of that health equity piece is we don't have the access to this treatment. Who has access to this specialized non-covered surgery? We have to kind of put that hat on. So if health equity is your jam, think about that. Do that research. Figure out how we can get access to care for people with this disease. I'm giving you all these wonderful career tips I wish I had when I was 18. So then I'm switching to self-advocacy. So you find out that you have endometriosis or your loved one has endometriosis. We've talked about speaking up for yourself. Katrina talked about going into the doctor's office with stacks of research and saying, this is what's wrong with me, fix it, right? Do that. You are the expert of your body. You know your body better than anyone else. And if someone's telling you, you probably just have appendicitis, you probably just have the stomach flu, you say, thank you so much, next, and you go to the next person. You find the clinician that's going to help you. And you do that until you're in the right place. And I think it was Dr. Poindexter who said matching with the right person and finding the right clinician and getting with the best team. You want to be with the right team of people to make your health. You navigate this treatment plan for yourself. Again, not just endometriosis. So if endometriosis isn't your thing, I'm just speaking to any health condition, right? And if it's not you and you're a caregiver, help someone else do the same thing. So I think we're thinking about showing up for yourself, speaking out for yourself, taking care of yourself, and then knowing whether or not something's best for you. I knew that Lupron wasn't my jam. I knew that going into menopause at 19, that I had to stop doing that. So I had to put a hard pause on that. And I had to say, no, thank you. No, thank you. But what else do you have? What's the next thing? And my doctor said, physical therapy is an option. Therapy is an option. I was like, okay, let's try those things. We have to find out what works for you. And so knowing like when to say no and when to say yes, and when to try something and when to stop something. But you make those decisions. Don't ever let someone force you into doing something. At the same time, we've talked a lot about fertility, preserving fertility. You don't have to do that if you don't want to. I knew that having children wasn't for me. And so I'm not having conversations about fertility when I go to the doctor's office. That's not the only thing we're talking about. I'm talking about pain management. So you want to talk about what is necessary for you and what's necessary for your body, self-advocacy. But remember to speak up and be proud because this is your body. You only get one. Have to take care of it. So that is my spiel about outward advocacy and self-advocacy. Whatever you have to do to make those two things happen. Okay, I'm good. I was worried about time, but I did it under 5:30. Thanks, Vanessa.
Yes, you did. And so thank you so much. You're gifted at your ability to take everybody's story and put it together and to be motivating. So class of 20, I guess 2010, kudos to you. We do now have time for questions. So if you have questions in the chat where you could raise your hand, we're open. We're relatively small in number. So please type any questions or raise your hand if you have questions for our panelists.
I have a question. Can you hear me?
Yes.
I didn't know that endometriosis came in stages. So what is the highest stage? One of the speakers said she had stage 4. And what makes it go outside of the lining? Hello?
Can I address that? Do we have the slide deck?
Yes, I have it.
Okay.
Give me a moment.
So I think I may have glossed over kind of what the theory is on how endometriosis happens. One of the prevailing theories is that it happens with retrograde menstruation, meaning they have reflux of menses through the fallopian tubes, and that can cause the implantation of that tissue from the lining of the uterus, or the tissue-like tissue from the lining of the uterus that gets implanted outside. And so that picture that you see is normal uterus, or what looks like a normal uterus. So the uterus.
There's something going on volume.
That normal uterus and fallopian tubes, and then the picture that was next to it, that's an example of stage 4 endometriosis, and it's considered stage 4 because you can see scar tissue. The ovary is attached to the back side of the uterus there. The right ovary and the left ovary, they're kind of kissing on the back side of the uterus. And then on that right ovary, that's an example of an endometrioma. And so just by the implant scar tissue in endometrioma, that's considered stage 4. Minimal endometriosis would be stage 1, and that's where we may just see implants of tissue, but not scar tissue and not scarring. And then stage 2, we may see more of those implants and deeper implants. And then when we get to stage 3, that's when we're going to see that scarring and that scar tissue and attachment of organs together. And so what causes more of the distant involvement, because there are some rare forms of endometriosis that can actually affect the lungs. You can have implants of endometrial-like tissue in the lungs. And it's wild because patients can have coughing and coughing up blood and these lung manifestations that cyclically happen with their period. And so the thought process is that that retrograde endometriosis then, or endometrial-like tissue then gets into the lungs. And so it may be, there's other theories about how endometriosis gets to distant implants. So it may also be related to the lymphatic system or the circulatory system to get these implants outside of the uterus and near the uterus.
Thank you.
Are there any other questions?
In the chat, someone asked if endometriosis is hereditary.
So there can be a hereditary nature to endometriosis. And you know, the title of this this talk is Endometriosis: What Your Mother Didn't Tell You, right? And one of the symptoms of painful periods, you know, the tricky thing is that our parents may, or our moms may tell us that this is normal. This is how my periods are. This is how my periods were. This is how my mom's periods were. But it's abnormal, and it may have been abnormal because your grandma may have had endometriosis, your mama may have had endometriosis, and now you're having that same symptom, and we think it's this is how periods are, but it could be an indication of disease.
I have a question for Dr. Dance. Dr. Dance, could you share with us a little bit more about guided imagery and acupuncture therapy to help individuals control pain?
Sure. So, complementary medicine or integrative practices for endometriosis can be very helpful. I specifically love to focus on guided imagery, meditation, deep breathing, especially during painful moments. So even for those of us who are sitting on this call, don't think about it, but you may be clenching your jaw, your tongue may be at the roof of your mouth, your shoulders tense, your butt cheeks, we're tense in the most, weird ways. If you have pelvic pain, you're also like clenching all of those muscles. And if you're going through a flare, you may just be like holding it all in. So our core is really tight. And so the guided imagery that I created kind of allows, it's a body scan that kind of makes us think of how to relax our body from the crown of our head and through our body. It helps with sleeping. It helps, just relax those muscles. It also talks about allowing blood to flow a little more easily. And so for me, guided imagery has been especially helpful for pelvic pain. It's also been shown to help with, like, if you're getting dental work done, people listen to guided imageries and hypnosis, and it helps you bleed less during like dental work. So it's research has shown that this is helpful, helps with heart attacks, helps with GI pain, really great work. Acupuncture is also really helpful, to your point. That helps, again, release some of those like trigger points that we have in our bodies. Again, chiropractic kind of like loosens up those tension points down along the spine, down the neck. So I'm all for trying something different, especially if you're like me, I was like, I can't take pain meds anymore. I just couldn't do it. So try something different.
Thank you so much. We have a few questions that we'll take in the chat. I know we've run a little bit over, but I appreciate the audience and their patience and wanting to give them an opportunity to interact. One question is, having your menstrual cycle early, say starting at 10 or 11, a symptom of endometriosis, or is that something that somebody needs to be worrying about if they start their cycle a little bit earlier than normal?
I don't know who's taking the medical questions. That's why I'm not answering, because I'm not an MD. So I'm looking at Dr. Poindexter, Dr. Johnson to answer those questions.
So yeah, that may be a risk factor. And the thought is that prolonged exposure to estrogen, which can happen with early onset menses, although 10, 11 is more of an average, that may be an association with endometriosis.
Thank you. There's another question that says that I've had conversations with the doctor about painful periods. They don't occur often, but when they do, they're horrible. Should this be something that I should continue to discuss with my doctor? So far, they've only suggested using painkillers during the week before my period.
I can take that one because I know that story all too well. So I had times where it wasn't that bad and then it would increase just depending. I don't know. It just depended. Definitely keep pressing them. And if they're not listening to you, I say definitely go to a different person so that they will listen to you. I know it's a lot of time and it's a lot of work, but you don't want to constantly have to take ibuprofen or those strong pain meds, because after a while it's just, you don't want to have to take those all the time, and you want to know what's going on. So keep pressing them and keep saying there is something wrong. And like they said, and everybody has said, if they're not listening to you, then you need to go find a different opinion.
I love that response. I was wearing my clinical trials hat today, so I wasn't answering too much of the medical, but I did, in our conversations earlier, remember we talked about tracking your pain. Even though, your perception of what may not be often may look different on a document. So I think I'm not sure if Dr. Deans put that out there, but it might have been a tracker for pain. Yes, so thank you. That's an awesome way to start off with. So you have something to take to your doctor versus just articulating it. They can see it, looks totally different. And I've learned something too in doing clinical trials over the years, is that we tend to adapt, right? We wear all these hats, we're women, we're strong, and we adapt to things that are going on in our life. I heard the warriors talk about it. And so you really, when you're keeping a diary, you can really associate it with what you do. I that pain that you think is normal is not normal all the time. So if you document it and it's in a diary and they can actually see it, then it makes a bigger difference.
The last question in the chat, what is the difference between endometriosis and adenomyosis?
So I can take that. I kind of describe adenomyosis as kind of a relative of endometriosis. And when we talk about the endometrial-like tissue that gets implanted outside of the uterus, and that endometrial-like tissue becomes embedded in the wall of the uterus, and that's what adenomyosis is. So it's more of a location on where that endometrial-like tissue is implanted. That's probably my best explanation of what adenomyosis is. But there are similar symptoms with adenomyosis and endometriosis. So it also has the pelvic pain, may have pain with intercourse, abnormal uterine bleeding. All of those can occur with adenomyosis.
So I think that is our last question. Again, I want to thank all of our panelists, our warriors, our clinicians for their time. This has been an amazing webinar. And I am want to thank our audience for your thoughtful questions, and I'm going to turn our program over to our national president, Kiva Wright-Berry.
Good afternoon, and thank you, everyone. I know there might be some problems with my sound, but hopefully you'll be able to hear me. First of all, I want to thank everyone for attending today. Our panelists as well as our audience for this information, which I hope has been beneficial and educational for all of you. This is the final webinar that will be sponsored by our NAASC Health and Wellness Committee for this program year. However, we do have one more event that I want to bring to your attention. As a part of our partnership with the March of Dimes, NAASC will participate in the March for Babies, a Mother of a Movement, and our goal is to raise awareness of the unequal impacts that Black women face during pregnancy and childbirth, and to raise dollars to find research solutions. We have several ways that you can participate with us. You can join the NAASC team at www.marchforbabies.org/NAASC. We've combined all of our regions and chapters into one single team. We ask also that you take pictures and post them on social media at NAASC and at March for Babies. And then finally, you can also visit marchforbabies.org to learn more about the different ways you can participate. And then finally, please consider joining NAASC for our inaugural True Blue Sister Summit, a women's empowerment event to be held in Chicago, July 7th through 10th, 2022. You can get more information about that online visiting naasc.org or True Blue Sister Summit /that. Thanks again to everyone for participating, and please enjoy the rest of your evening. Good night.